I am an EMIM grad. As I said, I'm super excited to be here to talk to you a little bit about communication in the time of COVID. The University of Washington said that today was going to be New York State's peak. We'll see about that. And so I'm sending all the vibes, positive vibes your way. And I hope that they are right. So we can get a little bit of respite, or you guys can. So I'm Clarissa. I'm an EMIM grad. I'm currently the medical director at Cure Health, which is a medical startup that uses AI to enable doctors to be more efficient as they give care to patients. And I'm also a palliative care attending at Highland Hospital. Can everybody hear me okay? Yes, okay, cool. And so, let's go ahead and get started. Oh no, why can I not? Oh, okay, great. Objectives for today's talk. I'm going to talk a little bit about what we know about COVID-19, which you guys are experts on. We'll talk about the limitations that it causes when it comes to communication. We'll talk about how technology can help, touch on telemedicine etiquette, talk about code status in the time of COVID, and I'll talk a little bit about informed assent as a concept, and maybe we can touch on most. And if you will allow, I'd love to just do a group check-in on how all of this is impacting you, or just take a ton of questions. Let's get started. What do we know about COVID-19? Is not a whole heck of a lot. It is a novel disease, but we know that it affects older folks and the vulnerable. And if you've worked in Brooklyn for more than a shift, you know that that is a really big term that applies to a lot of the patients we see. In addition to that, the patients that we see often have chronic illnesses such as hypertension, heart failure, pulmonary disease, and obesity, all of which we know tend to make COVID just a tougher disease to overcome. And we know that once patients develop respiratory failure, they don't do so well. And that's shown in the literature. And Shahryar would say to you, the literature is a little bit of a mess, and he so kindly shared an NNT link that spoke to it. It's hard to compare what happened in China, and the studies are retrospective, and it's sort of a researcher's nightmare to kind of put all this stuff together. But what we do know is that once people are unable to breathe, that they don't do so great. And the rates of that are variable, but they're bad, even when they're less in terms of mortality and bad outcomes. They're just not great. And so that's important to know, and contrast that with what we hear in the media and in pop culture, right? Does anybody know who this is? It's okay if you don't. So this is Italica Gondrona, and she's this beautiful 102-year-old woman who overcame COVID-19. And so the important thing to know there is not that this is Italica Gondrona, but that peppered with these super scary CNN reports and Fox News, whatever, you get these stories of hope that are wonderful and that are important to speak to. But this really does, and I'll use the same word again, pepper people's perception of what is doable and possible. And it's important to know that this beautiful 102-year-old lady didn't get intubated. She doesn't really match up when it comes to the potential outcome for other patients. But that patients' families don't know that. And so it's extremely important that we are constantly communicating our concerns with patients and families. And so that's great. Communication, awesome. But guess what? COVID is posing a ton of barriers to us communicating as effectively as we'd like. And they include that the patient, first of all, is all by their lonesome. Their advocates are not at the bedside because you're just not allowed. Another really big thing that's happening is that because of having to protect ourselves, we are having difficulty communicating with patients. When I have a face shield and a mask, my voice is muffled and people can't see my facial expressions, which are very, very intense. So if they can't do that, then I can't really communicate as lovely as I'd like to with a patient and their families. With a patient, the families aren't even there, so that's tough to do. And it's also difficult to communicate somebody because of the nature of the illness, right? It's hard to talk when you're short of breath. Add to that the fact that the census is up, right? And so you have too many patients, you're super busy, constantly hearing code 99 above you. All these things pose challenges to good communication. I wanted to share this because I thought it was such a cute idea. This is a respiratory tech who wanted patients to feel that there was a smiling face behind all the PPE, and so he laminated a picture of himself smiling so that patients knew there was somebody wonderful and a smiley on the other side. And so I just thought that was really sweet. At any point, if anybody needs to stop me, go ahead. It's difficult for me to keep on top of the chat, so feel free to just cut me off, and this can be sort of an open discussion. Technology can be really helpful at this time because, as we know, because we use it all day long, it really allows us to have contact with people remotely, right? We're doing it right now. It's 6-something in California. It is an easy way of ensuring that patients and medical teams are communicating and reaching out to family members. And it's wonderful because it keeps everybody safe, right? Family members don't have to come into a COVID full room to engage in goals of care discussions or treatment plans, etc. But technology poses some limitations, and so that's important to note and be aware of. I ran a telepalliative medicine service for 4 years, and it was a fantastic opportunity to provide care to patients who wouldn't otherwise have it, patients who were marginalized. It was great. But I, a proponent of telemedicine, can speak to the fact that it'll never be like holding somebody's hand, smelling a room, getting a sense of what's happening. Technology often takes away your situational awareness, especially with what you guys are going to be using, which is the telephone. You can see people's facial expressions. You can see people's reactions. You can hear, but you can't always see people's subtle reactions to a statement you're making. Relationship across the room, a husband and wife, when you're delivering bad news, and that those nonverbal signs are lost. And even with video, which is a fantastic way of communicating, that you're able to get some situational awareness, but it goes as far as the tablet or video allows. And so there are limitations, but it's still a really great way of engaging in communication with folks. And the way that you prevent the loss of that situational awareness or lack of connection is by engaging in some very basic, very Captain Obvious telemedicine etiquette. You want to ensure that you're introducing yourself and being very, very specific about your role, your location, your relationship with the patient, and where you are, what you're doing, so that you can give the family member on the receiving end some situational awareness, and they have a sense of what's going on, who you are, what's your relationship to the patient. You want to then acknowledge everybody that's either on the video or on the call. You want to ask what their relationships are to the patient. This is important for documentation, as this is important whenever you're engaging in documenting a call or any goals of care discussions. But it also is a nice way of saying, I see you, and you don't really see them, but you know what I mean. Um, you want to make sure that everybody can hear you. And so saying, can you hear me? Is that clear? Taking a moment to say that did that come through? Can you hear me? And checking in throughout a conversation not only makes sure that you're communicating well, but it also shows that, wow, this doctor really wants to make sure, isn't just dumping information to us. They really are relating and trying to ensure that that I'm well informed. And you want to make sure that you have ample time. You give ample time for answers. So you don't want to just be like, answer question. You want to allow a little bit of time, especially with video lags. If you do video lags, and if you end up using video, the hospital Wi-Fi's are notoriously not great, and so you want to make sure that you're allowing some time for that awkward lag of video between one person and the other to make sure that people are answering fully. And because you don't have the visual over the phone, that you give some time. And you can even say, are you done? I have another question, and see where that takes you. And I think another thing that's really important is you want to make sure that you're calling out the awkwardness of the situation and how tough this really is. Calling the elephant in the room out is really a wonderful way of just putting everybody on at the same level. And so with this, you will be better prepared to have a code status conversation, or deliver bad news, or update a patient and family member. And so a bunch of palliative EM people got together and put this on the ASAP website. And I will send this to Ronnie and Jimmy and make sure that this is dispensed to you so you have a copy of it. But basically it's a guide to start a conversation. And I want to say, we'll go through it, but I want to say that this is really hard. Goals of care discussions, as you know them from when you rotated in medicine, or your medicine rotation, or if you did a palliative care rotation, can take a really, really long time. This is a very quick guide is made by ER doctors, and so please know that. But I want to say that this isn't an ideal time, and this is really hard, and it's going to be imperfect. And I think that I want to make sure that you know that you have to just make peace with the fact that this is hard and imperfect. And I want to contrast the hardness of this with how hard it is to code somebody over and over again, or to code 7 people in a row. And so pick your hard, right? I mean, I think that's worth thinking about. And I'm on a soapbox, and forgive me, I tend to advocate for this a lot, and I'm happy to debate it. But to just shrug our shoulders and say this is hard and it's going to be imperfect isn't an answer that really is patient-centered. And so I'm happy to debate that more. I think another really important thing before I go into this is to really ask yourself what the goal of this is. If your goal is to get the DNR, you are not always going to be successful. If your goal is that I'm going to gather data and give data to a patient's family member, then even if you don't get the DNR, or even if you are surprised by somebody's wishes or the plan, you'll always be successful, because you're giving information and getting information that better helps you take care of patients. This specifically is for patients where we're likely de-escalating care, but all these tools can be used with any goals of care discussion. So just to get us started, you're picking the right patient, and at the top of the chart, you can see that it gives you who these folks are likely to be. And in Brooklyn, it may be slightly different, as we discussed before. You want to first ask what they know. You want to get a perception of, like, do they know how sick the patient is, or are they aware of the path through the healthcare system that the patient has had so far? So if Dr. Satapshi called the family at 3 in the morning and let them know this is what's happening, you might want to say, what's the last thing that you were able to share with Dr. Satapshi? If, like, you're about to, somebody's tanking or not doing well. You then want to break bad news. And we do this in palliative care. The terms we use is we want to give somebody a warning shot, and we want to make sure that there's a headline. So you want to prepare them. I'm afraid I have some bad news, and I'm going to share them with you now. Asking permission is nice. Would it be okay if I share? And you may not always get an answer, but it's nice to pose a question. Asking permission makes people feel really empowered, that they're they have control over the conversation in a very tough situation where there is no control. If you do anything with this conversation, it's to make sure that the takeaway is the headline. It has to have no medical jargon. It has to be simple, and it has to speak to what's happening. So an example of a headline would be, your mom is not breathing well. She is worsening. And because of her medical issues, I'm really worried that she's going to get sicker, that she's going to stop breathing, that she's going to die. The headline has to be really clear. You want to allow that to be received, and then quickly move to establishing the urgency, but also to align. And this is another term we use in palliative care, aligning. What that means is we want to recruit the loved one to help us make decisions. That makes them feel like I'm part of the team, but more importantly, I have a team to help me make decisions. So you would say something like, we need to work quickly together so that we can make a plan that makes sense for mom. Then you want to see where the patient's at. If a patient comes from a nursing home, you know their baseline function. But it's important to also gauge that perception piece, right? Does the family understand how sick mom is? And that also helps you guide them better. But for patients that come from the community, understanding their baseline functional status is really important, because as we know, functional status speaks to survivability in critical illness. And so if somebody is not walking, not feeding themselves, not dressing themselves, their mortality is way, way higher. And again, with COVID, everybody is just getting really sick really fast, but it is always worth assessing kind of what people's baselines are. And it also helps when it comes to recommendations. Asking what type of activities was mom engaging in may be really hard for them to say, but you can ask specific questions like, was mom dressing herself? Was mom living by herself? Was mom able to go to the store and care for herself, cooking for herself? The follow-up would be to assess patients' values. And it says here, select the appropriate questions, and I find that hard. A lot of pressure. Basically, you want to know whether the patient has expressed their goals of care in general. And what that means is, have they expressed their wishes in case of a critical illness? Have they ever, as a family, had a critically ill loved one that was on a breathing machine? And did mom ever express anything about that? And there's a bunch of questions here that you can see can be somewhat polarizing. How much would she be willing to go through to live, which is a tough question to ask. What makes your mom's life worth living? That's a tough one. But I think important questions to ask. Remember that if you put your foot in your mouth, you don't want to ever do that. But if you do, you're a human being, and it's okay to apologize. That didn't come out the way I wanted it. Let me take a step back. Let me rephrase that. If it's not received well, you can always take a step back. I think once you know that you are allowed to put your foot in your mouth, it'll make communication a little bit easier. When you're trying to assess patients' values, you'll often get, I don't know what my mom would have wanted. That's a very common thing that I hear. And so I ask, well, tell me more about her. And as an ER doctor, alarms are going off like, what? This is going to take 20 minutes. But in reality, it doesn't really. It feels like a long time, but it's not always. And you can always speak to the urgency and say, oh, that's really helpful, and move on to the next thing. But often you'll hear patients, family members speak to the fact that my mom's the matriarch. She cooked every Sunday. She took a lot of pride in wearing her makeup and her dresses and caring for her home and being a senior elder at our church. and she's a woman of faith, and she is scared of dying. All these things are really helpful in you assessing who this person is. Because if somebody takes a lot of pride in the way they look, and in caring for others, and in having loving relationships with and interactive relationships with their loved ones, being trached and pegged isn't usually in line with their wishes. And so, again, super helpful to assess the patient's values. You follow that with a summary. What I hear you say is that mom was walking and talking and cooking for herself until the day that you called 911. And that when your dad died, she was not happy with the fact that he was on the vent for a week. Does that make sense? Is that right? Once they're aligned with you on that and say yes, or they add, or they take away, you want to make recommendations. Based on what you said about your mom, we want to make every available treatment, and we want to give her every available treatment so that we help her recover from this illness. For her, given her values and given her medical problems and given what you share, I would recommend that we really focus on X, her comfort, her breathing comfortable, making sure that we dampen or assuage her anxiety. We will do X. We will give her antibiotics. We will give her oxygen. We will give her anti-anxiety medication. And we will not put her on a breathing machine and give her medications that put her to sleep and don't allow her to interact. And you let that sink in. And in a patient who is not on the top of the list and who there may be some debate, it's important to really go back to aligning the goals and the values of the patient and what treatment could do. And we can talk about that more in the following slides. The last thing is you want to forecast. You want to make sure that you say, I hope this works. And we're going to do everything in our power to help mom. But I'm really worried about how sick she is. And then here you'll insert what the next steps are. So strategizing and the follow-up is really important. You're not going to be the person that's going to call her back. So having some knowledge of what's happening downstream is important. The ICU team will call you. I'm admitting her to Dr. Masola, so she'll call you in the next few hours to assess what's going on. And so that is the process. Again, I will send this to all of you. Is there anything anybody wants to say, or should I keep going and then we'll talk when I'm done? Okay, so I'll continue. A word about informed consent versus informed assent. So you guys know the word assent from pediatrics, right? Because you did P's in your, when you did oncology, you heard a lot about about assent, where a child will agree to a treatment, a clinical trial, chemotherapy, and a decision has been made by the parents and the oncologist weighing risk and benefits. And so this is an ethics term that we use a lot in pediatrics, but it fits into the palliative care and decision-making world as well. You have informed consent, which patient gets information about risk, benefits, and then they make a decision based on that. And with assent, you have a physician providing information on the risk and the benefits of the treatment. And you then provide specific recommendations. And so I appreciate informed assent because you're not giving people a menu, pick from this, but rather you're saying, I'm bringing my expertise and I'm taking that burden of navigating through the medical information, your mom's values, and I'm making a recommendation that I believe makes sense given what I know, so that family members can get a sense of what's possible, right? I think the most important thing here is that family members can disagree, and family members can say no. But this also takes the burden away. And patients, especially with really serious things like palliative sedation, for example, appreciate assent, appreciate guidance, as opposed to be like, here, you're responsible for for your mother's death or the end of their life. That's what people are perceiving. So if you make a recommendation about this is the illness, this is not something that you have control of, it really is really helpful. And so that's what I'll say about that. Just a brief note about most. In New York State, so first, documentation is important when there's chaos. With 7 codes coming in, admitting everybody to the ICU, making sure that you have good documentation is really, really key. And so most are great because even though they're paper and we should all be doing emails, they're pink, and so at least somebody can find that in a chaotic situation. But obviously you want to write everything in your note as well. Even with chaos and even with people loosening regulations, you want to be strategic and very good about documenting, because 10 months from now, there'll be a ton of scrutiny on what we're doing. And so as best as you can, as succinctly as you can, make sure you're documenting well. But anyway, in New York State, you don't need a physical signature from a DPOA, decision maker, or healthcare proxy to do a MOLS. However, you do need a witness. And so the one thing I want to say here is, like, if you're on the phone and it's chaotic, make sure you identify somebody that can help you witness a conversation. You don't want to make an already awkward moment more awkward. It can be anybody that you work with. It could be a clerk, it could be a tech, but you want to identify somebody. They don't have to be there for the whole conversation. They can just be there for the summary. They need to hear that there is agreement with the plan that you're laying out, and will be populated into the MOLS. It can also be a family member. If there's 2 people on the call, that's perfectly legal as well. I now would like to speak briefly about death notification. I want to say that I'm sorry, and you're probably doing this a lot, and it's really sad, and maybe there's also chaplains doing this. It's a little bananas that this is happening, period. But I want to speak to death notification as a procedure. Just like when you're intubating somebody or putting in a central line, you follow steps so that if there's a fist fight outside of the trauma room, or if the patient's leg is falling off right before you're intubating them, that the chaos of the situation, while it can affect you, doesn't keep you from sticking to the protocol. And so if you look at death notification, delivering bad news as a protocol, and have a tool, then you can make sure, no matter what kind of emotion the patient or family has, that you are sticking to all the elements of it. And so I like spikes. There are many tools out there, and they all pretty much speak to the same things. You first want to make sure that you're setting up for this delivery of news. And so I like to tell people, especially on the phone, I have some serious news about your mom. Is now a good time? Or I need you to find a quiet space. If it needs to happen, then I need you to find a quiet space. I've called many people in my telemedicine work, and people are driving, and it's important that I notify them. So I have them pull over. Driving, bad news, not great. And so you want to make sure that the person on the other end is safe. Then you want perception. You want to assess what they knew about what was going on, just like we did with the code status assessment. Is like, tell me what you know. When was the last time you saw mom? Tell me what your what Dr. Satabchi said when you had brought her in, or when you called in. I is for invitation, and that means that you are going to say, I have some really bad news, and I want to share them now with you. Is that okay? That can be more prescriptive. That can be, that warning shot. I'm going to give you some information about mom. I hope that's okay. And then you can go into knowledge. You want to go ahead and give the information. After you call 911, when mom got picked up by EMS, she stopped breathing, and the EMTs intubated her. By the time she came into the emergency room, she had lost her pulse. She had died at that point, and we started doing the resuscitation to get her heart to start pumping again. We gave medications, we did procedures to resuscitate her, but unfortunately at 3:23 p.m., your mom died. I'm so sorry. You have to say the D word. I've been doing this work for a while, and there's really smart, caring, loving physicians that when they have to say the D word, they stroke out. And so I want you to practice with yourself to say the D word. Euphemisms, not great. With cultural barriers, you have to be really clear in your language. And so, death, died, died. You can pillow it, you can cushion it, but you have to say the D word. And I know you hear this all the time, but we do it all the time. And I, as a palliative care doctor, catch myself struggling to say it. And so I just want to call that out. You want to pause, and then you want to allow the emotion to come out, and you want to address it. And we'll talk about that shortly. And then you want to strategize and summarize. Basically, you want to make sure that people have a plan for after this. You, as a resident, aren't going to give them your personal cell phone because it's a hard time, and the last thing you need is when you're off to helping people figure things out. I would ask that you tell your administrator, your clerk, whoever's in charge, what are we telling families about the bodies? There's all these FEMA trucks out there. What can the expectation be? Who can they call? That would be really helpful at the beginning of the shift in case you need to do that, so that you're not saying, here's my number, call me, or the social worker will reach out to you. No, you know that's not happening. And so have a plan. And you may be, things are really stressful right now. You may not hear from us for a while. But we will reach out, and I'm really sorry. When you're addressing emotion, you can use nurse statements, and basically what they mean is that you're naming the emotion. I can see that this sounds that you're very sad. Understand, I can't imagine how hard this must be for you. You want to show respect. I know that you did everything in your power to take care of mom. Support, again, in this case, you're not going to be that person. I'm available for you. You want to say, at Downstate, we really care for our patients, and we'll reach out. X person will reach out. This is a number you can call. And this isn't always super helpful for death notification, but sometimes just asking someone to tell you more can help end a conversation and close a door on a discussion, but also just build more rapport where appropriate. And so that is what I have to say about that. I'm happy to take questions, but I also want to bring up this really important thing. And my hope is that I help start a conversation amongst you all. And I know you guys are doing a lot for self-care, or trying to, or at least thinking about it. But I want to say that never in our lives have we had an extra layer of anxiety, sort of this anxiety that lives at work with us. And that is ambient anxiety. What I mean is this idea that by virtue of walking into the place you love, doing the work you love, that you are feeling the sense of danger, that your safety is at risk. And that is a layer of anxiety that was never there before. Even though you work in a place where, your life is threatened from time to time, and, you've been shoved maybe once or twice, this is a higher level of anxiety, and it's there all the time. And it's visible because you have to wear PPE, if available, hopefully continues to be available. And your nurses feel it, and your clerks feel it, and the techs feel it, and it's there all the time. And add to that the fact that you are in a place and in a universe that you didn't expect would happen, where you can't hug the people you love, where you can't go where you want to go. Add to that the fact that you're seeing incredible amount of mortality. Add to that many of us may feel that our government isn't supporting us and valuing us as human beings, let alone medical practitioners. There is a collective sorrow, a sadness, and that is leading us to have a ton of emotion, whether it's you're having an extra glass of wine, you're not being social the way you usually are, you're eating your feelings, having that extra cinnamon bun. That has a name, and the name for that is grief. And it's a collective grief, but I think it's worth speaking about it. And I wonder if anybody feels brave enough and vulnerable enough to share if any of those two terms resonates with them and would like to talk about it. So I'm done and would love to hear from anybody who's willing to share. And I'm also happy to answer questions if people are feeling shy about it, talking feelings.
Hey, hi, Dr. Rios. Thank you for giving this great lecture. I'm Priscilla. I'm one of the PGY3s. So I haven't been in the ED. I'm on staycation, but I've been helping to coordinate some food for our departments. But two things in regards to the ambient anxiety, definitely experience that. I definitely see myself drinking a lot more than I usually do with every meal. Okay, I lied. Not every meal. Everyone in there, please don't panic. But that's one. And it definitely pervades everything. My first shift back is tomorrow, so I'll be fine. So that I acknowledge that. I realize that we've been hosting, Zoom sessions with all our classmates and so forth, co-residents, and that has helped. And I've told everyone I'm scared. I'm anxious. So that's that. That's related to that, not to dismiss that, but the question I had earlier when you were talking about the code discussion, I'm sure, before COVID even happened, we all had to deal with this, having to talk about death with any patient's family members when they weren't present at the bedside or even when they were present at bedside. So I have encountered, and I'm sure a lot of my colleagues can say the same, when patients' families will say, I believe in God, I believe in faith. If I pray, my family member will come back. They will be, this sense of denial that you get. And as the physician, you know that is unlikely. And it's hard to, it's not, I see logically that it's denial. I see logically as a physician that it's not my position to correct them, to make them see my point of view. But I don't usually know how to, usually I just give up and say, okay, we're going to move forward. Let the patient, your family member's going to go upstairs. They're going to go to ICU, medicine, and the medicine team, or I basically turf it. So, I don't know if you have any suggestions about how to address that.
So first, I want to say thank you for being so open. And I want to say collectively that we all need to give ourselves a little bit of grace. This is a new world, right? So a couple of things that you said made me feel really good about the way you're coping with this. Is just kind of naming it, right? You're naming being scared. We know that the research shows that social support is the key to overcome this. Whether you're an introvert or an extrovert, whether you hate people or not, social support helps. Recognizing that you're reacting to the emotion is another really amazing, wonderful thing. And you're very brave, so thank you, Priscilla, for sharing. To speak to I'm holding out for a miracle, or I'm going to put this in God's hands. I work in Oakland, and basically our patients are very different. I call Highland Kings County light because it's just not as intense as Kings County, because Kings County is the best and downstate is the best. But yeah, very similar. And so I see this often. One of the things that is helpful is, you just said it. This is uncomfortable for me. I don't want to take away their hope. And so I'm going to turf it to medicine. If you're overwhelmed and they're saying full court press, it is very appropriate that when you are speaking to them that you say, I know this is hard. I think we're going to have to revisit this again. So even though you turfed it to them, you are expressing how incredibly sick the patient is, and express that it is very possible that very quickly we're going to have to come back to this conversation. So that's one thing. And that's a sort of like, if you can't do anything, do that. This will need to be revisited. Number two, another thing is to just ask, what does that look like? Tell me more. because often people will they'll throw you a bone that you can really latch onto and speak more to. When people say, I'm leaving this to God, or I'm holding out for a miracle, I like to say, and so I want you to think about that. If this is in God's hands, then nothing we do is going to change that. And that a miracle will happen whether or not we do this. And I'm afraid that in holding out for a miracle, we're causing more suffering for your mom. And those are some really, really heavy things to say. But what I think has helped me, and what I think I want to teach every learner, is that if you have a phrase, if you have an idea that is genuine to who you are as a person, then you practice it and script it so that you can use it in any stressful situation. Is that helpful?
Yes, it is. Thank you.
I just want to add that too, this is Willis, and Dr. Rios can correct me if I'm wrong because I've never worked on the medicine side, but often when I have that or I feel like I'm turfing it, I sign that out to the medicine team, and they often really appreciate the fact that you started that conversation, even if you didn't necessarily meet the objective or kind of get your thought process across. Starting the conversation is really important. And sometimes all we can do in the emergency department, just opening the family or healthcare or proxies mind open to that this is going to be something we're talking about. So sign that out to the medicine people. They usually appreciate that.
Yeah, and even if you put it in the note is really important. And as I said before, if your goal is to get the DNR, you're missing the point. It's about information sharing. It's about starting a conversation. And sometimes you have to be very directive. And I want you to think of CPR as any other medical procedure. You know, legally, Rachel Goldberg, I think is your lawyer, will be like, whoa, Clarissa. But think of CPR as a medical procedure as well. And so that you can speak to something being medically indicated or not as you're assessing, giving recommendations, right? But yes, I think starting a conversation, this is where we left it. We discuss a trial of intubation. We discuss that this is not, that in the next 48 hours, we may have to really come back together and discuss that this is no longer an option, that we're no longer caring for mom, so that we're not withdrawing care. We're just discontinuing things that no longer make sense. It is so important, you guys, that when you talk about recommendations, that you stay away from the words withdraw, futile. If it's futile, you shouldn't have done it in the first place, right? And so it's not withdrawing care if it wasn't caring for the patient. And so get rid of those words. We're going to do everything that's going to be helpful to mom. And that is to give her anxiety medication. And that is to give her oxygen. And that is to make sure she's warm, to make sure that she feels safe. Those things are really helpful. We are working with people that are marginalized, where they're constantly having things taken away from them, where doctors did things to their grandparents and their parents without their consent. And so how dare we introduce terms and make them feel that we're taking things away? And so be very cautious with your words. Okay, anybody else want to share a little bit about anything or ask questions?
I want to say something. Hi, Dr. Rios. It's Carolina.
Hi, Carolina.
So what I'm being encountered a lot every time that I try to have these conversations is that there's a big element of surprise when you tell the family that, hey, your family member likely have corona. And I think that maybe I'm not doing this conversation correctly, but they always get angry about my tone of voice, that they say that I'm being negative about the family situation, that they think that the family is going to get better, and they're not doing the best that I can. And after that, they get angry with me. And then the conversation is not going anywhere because they already think that I give up. And I really don't know what tone of voice use when you're having these conversations and how like introduce the term that your family member is really sick when they thought that everything was okay. And then they got into all this big discussion about why my family member have corona, you're not doing your job, why you're saying all these things, and then there's nothing else to say because we're not going anywhere after that. So I don't know what to say and how to say. I think it's the tone of voice that I'm using. I don't know how to change that.
So I always say that you need to make sure that you have a script and the tools, but everything has to be genuine to who you are. You're not going to sound squeaky like this, and nor do I want you to, because it's really not fun for me. But I think it's really important to be genuine to who you are, but use the tools. So number one, I wish I can say that mom is going to get better. I'm afraid that this coronavirus is taking over her lungs and not allowing her to breathe. And I wonder if we can talk about what that looks like. So I wish, I worry, I wonder statements are really helpful. I also think that you want to speak to everything you are doing. And Carolina, this is like where families can feel a little alienated or feel like you're taking things away. And so it's really important to speak to, we have done everything to help her breathing. We have worked really hard to do X, we're doing Y. I'm afraid that despite all these efforts, she's just not getting better. And just let that sit. And when people are like, tell me, you know, you're being negative, and I think at that point you want to name the emotion. I could imagine that people in your position, when they're hearing this news, would be really angry. Okay. You're naming it, you're understanding it. Tell me more. And I know it sounds crazy, you guys, but when you say the words "tell me more," it's like I'm surrendering to this situation. I'm all yours. Just destroy me if you have to. And I know it just feels like I don't have time for that. But I promise you that tell me more, like with your own personal relationships, it really does help open up communication in a far more effective way. And so the big takeaways are: speak to everything you've done. Speak to the fact that COVID is just so overwhelming. And as you have seen in the news, this is unprecedented disease. And it's not to just, you know, be negative, but it's just speaking to the truth. And then when somebody's jumping at you, to really name the emotion and allow for somebody to have that moment. Often what happens, and this happens with personal relationships as well, somebody gets mad and you just go like, bloop, I'm not dealing with that. Put it in a little bow and give it to medicine. That's okay, but it doesn't really help the patient and the family. And so allowing the emotion to for them to watch the situation with the emotion, just let it come through and name it and understand it and show respect. It is totally appropriate. You guys were not expecting this call. I could imagine that it would be so difficult to be speaking to somebody one day and then all of a sudden hear that they're dying. I am so sorry that you're having to go through this. All of these things are appropriate, but you're not going to say it the Clarita way. You're going to say it the Carolina way. You're just going to make sure that it's following. Name the emotion, share that you understand it, show that you're respecting it, that it's appropriate to be pissed, and strategize, you know. If for example they're saying, no, you go and intubate her, it's like, I completely understand, but we will have to revisit this again, and make sure that you are again exploring. So tell me more is a really great statement. Okay, anybody else? Sorry, I just went off.
Hi, this is Noah. I'm at conference right now.
Hi, Noah.
I had one question. So actually, in the ED right now at Kings County, I've been getting punted to from medicine for admitted patients and have spoken to a lot of families and have actually had the DNR, DNI discussions on patients that are not. Everybody in the ED is my patient in a sense. And so I end up having these conversations, and I kind of wonder to some degree if the DNR, DNI discussion is always the morally and ethically correct discussion. Are we giving patients or their families an option when we as physicians maybe have already determined that it's not medically indicated and also potentially harmful and putting us as clinicians at risk to even perform CPR or resuscitation or an intubation. So I struggle with when a family says, we want everything done, when I know that that's not the right thing and that it will not benefit them. Am I offering, kind of giving them this belief that we would do something that we can't do, that it would be harmful to them and us?
So I think it's really important to speak to that. And so assent in this case is important. This is a recommendation, and we will not be coding your mom in case of cardiopulmonary arrest because we do not feel that that would serve her. I want to be really clear that we want to be upfront with information, that we want to say, this isn't happening if it's not happening, right? We're not going to be like, oh, she's full code and then we're going to do this, right? That's not a thing. And so you want to be really clear, and you want to be ready for what that will lead to, right? And so the key thing, is that you want to make sure that you can help hold the family during this issue. Your mom is dying, and you want to set it up, right? I want to do everything. I hear that you want to do everything. It sounds to me like you want us to do everything that would be helpful. And because your mom is dying, I want to make sure that she dies with dignity, that she dies with comfort. And so for that reason, I want you to know that I want to do this and this and that. I don't want you to engage in a conversation where you're like, mom, sorry, my phone is ringing. I'm lecturing at Cook County and they're calling, but it's not for a while. Sorry. I don't want you to sell them a bill of goods that isn't what you're going to do. And so, you want me to do everything. I want to do everything that's helpful, but doing CPR on your mom right now would cause more harm. Doing CPR would be imperfect because of all the limitations that we have. I think that is really important to speak to the truth. I think it's important to speak to your medical decision making when you're documenting. Patient has a map of 20 on 3 pressors and is needing a PEEP of 55. If she were to code X, Y, and Z would happen, and therefore we're foregoing CPR based on X, Y, and Z. The other thing to keep in mind is that certain hospitals have what we call triage teams, and it might be something that you guys will be building out. I don't know, and honestly, I didn't have time to speak to Kathy Powderly about this, but basically what we're doing at Highland is we're setting up triage teams where ethicists, or a member of the ethics committee, a doctor and a nurse, get together and make decisions based on objective things. We look at SOAP scores, we look at patient's age, medical problems, and we make a decision about whether or not they should be intubated. Then we give that decision to the medical team and to palliative care. So it's an independent team altogether. And then they say, we will not be intubating mom because of X, Y, and Z. And so if decisions are being made about resource allocation, I think that makes sense. If you're making decisions based on clearly medical stuff, which is I think what you're asking, then speaking to that is really, really important. So honesty is super key. Anybody else have anything else to say? Was that helpful, Noah, or was that me?
No, that was, thank you.
Okay. Anybody else?
Hey, I'm Naomi. Nice to meet
Hi.
you.
Nice to meet you.
I'm saying something from my home. I just had a question. I am the type of person that wears her heart on her sleeve type of human. And I actually love having these conversations, but then I also find that it burdens my soul a lot, and I just sometimes don't know how to hide it when I'm like talking with the family. And I'm just wondering, for me not to be a burden to them as well if I'm crying too or just being overly emotional, how exactly do you address that on a personal level?
And so it's funny that you're saying that to me because anybody who knows me in the room knows that I cry at the commercials. So I think that it is okay to cry. It's okay to react emotionally to something. And it is, and that can really live with you continuing the conversation. And so often I'll be really emotional about something. Like I extubated a 37-year-old with COVID yesterday or 2 days ago, and it broke me. He was a non-documented immigrant. His mom had just, that 57-year-old mom has just died, and I was just having the feels. But I had to continue the conversation. The family was extremely grateful that I was vulnerable in front of them. I still stuck to the task. I think that hiding our emotions is a disservice. You don't want to be like, oh my God, this is so difficult for me. But you definitely don't want to do that. But if you tear up, if you have to take a minute, if you have to say, wow, this is really emotional, give me a second, that's perfectly fine. What you don't want to do is you don't want that to take over and railroad the conversation. And so I would say allow the emotion to kind of go through you, but really stay the course in terms of what the goal is. It's not about your emotion, it's about the family. The fact that you're reacting to it is perfectly fine, but stay on track. The other thing is to be okay with that. You know, it's funny, Kings County is a place where, you know, you can drop the F-bomb in the middle of a shift and nobody says anything. That is far more acceptable than shedding a tear. They're equal. Allow it to be. That is who you are. That says you're human. And so just allow it to happen. Just don't let it take over the conversation. And then make sure that you have a place to really unpack that. Whether it means you need a walk, you need to call your mom or a friend or your lover, do it. So that you can stay on task because patients need you. But you have to give yourself the grace to say, damn, this is freaking hard. And so I hope that's helpful.
Yeah, thank you. I had another question too.
Yeah.
This is because the type of people we deal with, they're so diverse, and we're all just so different. And especially now because we're having these conversations over the phone, how do you like switch the tone to be like in accordance with like their cultural beliefs and being culturally sensitive and appropriate to the situation, knowing their cultural and religious background might be like very different from what you believe is right, correct, or you don't know.
I think oh my God, I just got a text from Casey. I think you cannot be culturally sensitive to everything, right? That's not a thing. You can be aware, right? And so I think when you are speaking, you have to say the D word. That is a non-negotiable, independent of race. But I do think that what you can ask is, you can ask questions about what do you value, what's important to your mom, and these things are really helping the patient and family know and understand that you are trying to meet them where they are. That's kind of the number one thing that we want to do. And so asking questions that are patient specific then address sort of the cultural piece. In my mind, you know, I deal with patients of Chinese descent, Eritrean, Ethiopian, and, you know, often what gets me together is connecting with, like, you know, everybody knows what it's like to have a mom or have a dad, or, you know, oh, wow, she was a waitress, or something that helps you connect with them. Tell me more about who the person is. And then you can sort of speak to a very personal thing, and possibly kind of jump off onto the cultural component. I'll come back in the summer and we can talk about cultural awareness, not sensitivity, because again, that's competence. Sensitivity is one thing, but competence is not something that we all can do because there's just too many countries and too many cultures to become proficient in. Anybody else have any other questions?
Thank you, Cora.
Oh my God, look at Sarah's baby. Oh, sorry, Jimmy.
No, it's okay. We're just saying thank you.
Oh, okay, cool. So in closing, I want to say I have to run to Cook County, but it's great. I can run from my living room, my dining room. What you guys are doing is amazing, and I want to say that County Strong is like a real thing. And Dr. Lucchese, Dr. Holt, Jimmy can speak to this. Like, we are everywhere in the country, and we're all like sending you all the love.
Thank you so
It
much.
happened. I knew I was going to do this. I want to say thank you, and I send you all, like, all the hugs and all the kisses. And I got to run, but thank you for your time.